so I'll start off with the first question. I will ask Dr. Nelson, do you use continuous infusions at your institution? And if so, which ones for cesarean section? Thank you.
What was the second part of the question?
Do you use continuous vasopressor infusions for cesarean section at your institution? And if so, which one?
Okay, it wasn't a two-part question. Thanks for asking, Manny, because it gives me a chance to, pardon me, to tell my story. So, and it involves Rich Smiley, as I've already alluded to. And he wrote that editorial in 2009 saying, what the heck is wrong with everybody? Why are we not using infusions? And he specifically was going on, in the lecture I talked mostly about just phenylephrine or not, phenylephrine versus ephedrine, but he truly was advocating even not using bolusing. And that's just based on the fact that at that point, that's all the studies we had. That's what Warwick had done, is all these infusions. Because phenylephrine does have a little bit shorter duration of action than ephedrine, it kind of made sense to do that. So, you know, he and a lot of other people are, and as they should be, practicing evidence-based medicine. I think that's fantastic. But as I alluded to in the lecture, that's not how, we don't practice the way that Warwick did these studies when you look at bolusing and infusions. So I had a couple of experiences. So I adopted it. You know, I was shamed into doing it. I adopted infusions and started doing them, and you know, groaned every morning when there wasn't a resident or a nurse anesthesia student who would already have the stuff done for me, so I have to do it. And I'm like, I don't want to be doing all this work, and you know, because boluses is working just fine. No one's puking, getting sick or anything. And then I was noticing the charts. You look at the end of the record. These women are getting milligram doses, even multiple milligram doses of phenylephrine. When the patient right before, I'd given 3 80-mic boluses, and she did fine. And so it just seemed medically incorrect to me to be doing that. And so one of his colleagues, Stephanie Goodman, I had another conversation with at the ABA about a year later, and she shamed me back into trying infusions again. And we had a VIP. It was really fun. The day was great. It wasn't like in California where you guys have movie stars that come in and have their babies, but we do have NASCAR drivers. And this was a NASCAR wife. And if you don't know that, that's a thing, actually. Just Google NASCAR wife and you see it. Or if you haven't seen, we got a fan back there. If we haven't seen Will Ferrell's movie, Talladega Nights. Okay, that's what I'm talking about. So that was the one. Seriously, we were having a really good time. It was fun. It was a really nice environment. I was getting a lot of crap for having not recognized who he was or knowing anything about NASCAR. And everything was going great, C-section going well, spinal was perfect, everything was good. Right before, they were about to make incision in fascia, and she just became very, very quiet, and I was asking her what the problem was. She could barely even talk. She had an extreme headache. And I looked up and her blood pressure was 240 over 120, and you know, her heart rate, of course, was 50, and it just ruined the day. And not only that, but I thought she was going to stroke. I mean, I was really, really concerned about her. She ended up doing fine, everything was good, but again, just completely ruined the day. And that's when I turned to whoever's running the infusion, said, okay, that's it, I'm done with infusions. All right, that's my personal experience, and I think that what Rich and Stephanie would say was, well, that infusion was mismanaged, you just did it wrong. You were giving too much, you didn't back down in time when you got bradycardia and so forth. But what are you going to do when your blood pressure has been, she was one of those that starts out at about 105, you know, systolic. So what are you going to do when your blood pressure, you know, it's 110 systolic, their heart rate is down to 50. You know, I give ephedrine. I don't turn down the phenylephrine infusion. The next blood pressure was 220 over 140. So anyway, that's my experience, and a long answer to your question, Manny. The real answer is that we do it if we want to. Some people do, some people don't. Everyone has their own individual preferences, and I encourage everyone out there to develop your own individual preference. And if you're doing bolusing, don't wait for a blood pressure to cycle and then say, well, based on that pressure, I'll give 1 dose of phenylephrine and wait another minute for the next pressure to cycle. You know, that's not the way we practice.
Okay. And any other two want to comment? Go ahead.
I mean, I'll just, we sort of do a little bit of a combination. I would say almost on every patient we have a low-level phenylephrine infusion in the background. We're very quick to manipulate it up or down, and then we'll throw some boluses on top of it. Seeing Dr. Rosen back there, I remember a discussion I had with him about 10 years ago in the OR where I said, why aren't we using infusions? And he said, you're the infusion pump. So.
That's great.
I would like to say one thing. I think preoperative hydration has a role too. You know, giving that liter bolus before you do your regional technique does help with that drop in blood pressure.
Okay, good. The next question is for Dr. Ray. When is epidural analgesia contraindicated in patients with severe heart disease?
I don't think there's any absolute contraindication, like Dr. Rollins said, but what I would be careful about is how you dose it, and I'd be very slow, very careful, judicious. The only contraindication is when they're on anticoagulation, and you have to manage the anticoagulation, but there's no absolute contraindication.
Okay, anyone else want to chime in? Okay, next question, Dr. Rollins. Why do you think DPE is better for CSE for these patients than CSE for these patients?
I figured that question was going to come up. So, as you know, there's a nice study put out by Lawrence Sen recently who's in anesthesiology, not ANA, and he compared CSE and DPE and labor epidural. And you know, we'd already known some of the data from the CSE, if you did CSE compared to epidural, that you had a sort of higher rate of success or a lower rate of failure. But the downside was that your catheter sort of was untested initially. And so as an example, let's say you were going to do a cesarean section and you had someone with a significant cardiac lesion you were worried about, and you really didn't want a failed epidural, but you also wanted to make sure that the epidural worked well, you know, before you got going. Sort of the benefit of the DPE then, per his study, was that you got that benefit of knowing it was the epidural portion working because you were just poking a small hole, but potentially having the benefit of increasing your chance of not having a failed epidural. I don't know. I know Dr. Nelson next to me you had just given a talk at the ASA, didn't you, on CSEs and epidurals?
Yeah. I really don't have much to add to that. I think I mean, if Lawrence were here, he'd have something to say. But, you know, the studies that he did were 25 Whitakers as well. I don't know if you guys are using 25s or 27s. We use 27s, and the data aren't so clear for that. I still do them sometimes, though. I mean, there's really little downside. If your plan is to place an epidural and have it tested in these high-risk patients like Mark was talking about, then there's really little downside to putting a 27-gauge Whitaker hole in the dura to hope that it works better. So I practice that.
Okay.
You can also do a spinal catheter when you're really concerned.
But there are definite downsides to that.
Yeah, there are downsides for
That's
sure.
a whole other talk.
But
There's a long list of downsides.
yeah, but it's an option.
Okay, next question. Dr. Nelson and the rest of the panel. There's two questions basically regarding Zofran on Dancitron. And do you give pre-op dose of Zofran to help prevent hypotension? And is it your experience to use it in eliminating, or at least trying to eliminate spinal hypertension and potentially the need to use ephedrine or phenylephrine?
Right, so the first part, Zofran, I don't routinely, I don't know about all of my colleagues, based on the available data, they're not very strong for an effect. If it's going to do anything, it does help, and so I think that's fine if you're doing that. Just know that Zofran is a fairly benign drug, but not completely without side effects, and so that's why I don't do it. I mean, I don't like to empirically give drugs that I don't need. That's part of the reason I don't do phenylephrine infusions, for instance. So, no, I don't routinely do that, but I think it's okay if you want to do that. It does have some effect on supporting or at least reducing the incidence of hypotension. The second part was ephedrine.
Yeah, have you noticed by using Zofran, does it decrease your need for
Yeah.
ephedrine or?
Well, I have to defer to my colleagues who might be using Zofran routinely to try to help prevent hypotension, because I don't.
It's not something I've noticed. I'd say the majority of our patients do get Zofran.
I'm only using Zofran for treatment of vomiting, not prophylaxis, so I haven't seen that.
Okay. Next question for Dr. Ray. What's your experience with the use of vasopressin and congenital heart disease or hypotension?
I haven't used vasopressin in the OB setting, I've only used it off bypass, so I don't have a lot of experience with it. I tend to use phenylephrine as my go-to vasopressor in the labor and delivery setting.
Okay, anyone else?
I mean, I know there's case reports out there where it's been used successfully without problems, but I don't know of any studies where it's actually been looked at.
Okay. The next question is Dr. Nelson. Weight-based dosing, actual weight or lean body weight or ideal weight for infusions?
Yeah, good question. So that, the only study I know of was done with bolusing, not infusions, and that was based on actual body weight. Warwick, one of his editorials, no, actually it's a new one that isn't published yet that he also shared with me, talks a little bit about that and would advise against, and I would as well, advise against using actual body weight as if you're doing it per kilo. Now, if you're doing infusions, of course, it doesn't matter because you're changing your infusion. It's a variable rate infusion based on what is occurring during the case. Bolusing, I stick with the recommendations of using just an absolute drug dose of somewhere between 80 and 120 mics per bolus.
Okay, anyone else want to add? It just seems to me too, if you're going to titrate to effect, so depending on whatever you use, you're eventually going to titrate, right?
Right. And if you use actual body weight, and I'm sure this is why this question was asked, certainly in the southeast where I practice, you're going to be giving some huge doses of phenylephrine to some patients. That it's, I mean, all kidding aside, it's going to be completely inappropriate. And so yeah, it's a good question.
Okay. This next question is for Dr. Rollins, and it's actually, I was going to ask it too, about TEE or TTE, and a clinical vignette from one of the audience members, P2G1 parturient, patient with uncorrected VSD diagnosed at age 8, TEE during prior pregnancy reported okay, not available for review, admitted for elective repeat cesarean section. What do you do?
If it's not available for review, I would speak with the OBs and our cardiologists, and I would like to get a TTE before proceeding just to see what's going on. I wouldn't want to take that report just at its word.
And how often do both of you use TTE in the operating room for patients, parturients with patients that have complex heart disease? Do you use it frequently, or is it often, or not often?
I mean, I'll speak just from my experience. So for patients that we end up doing a cesarean section in the operating room who have congenital heart disease, I would say we'll probably have it available 100% of the time, and then actually using it during the case just a fraction of that. Mm-hmm. It's sort of like if everything's going well, we don't do it, but as soon as something takes a turn, we have it there available.
Okay. Yeah, it just seems to me to be really, really hard because of the drapes are up, the surgeons are there operating, and it'd be really difficult.
But I mean, I guess the caveat to that is if we choose general anesthesia, then we have a pretty low threshold to put a TEE down, which is a different question.
Right. I think in an emergent situation, a TTE is a great option. I haven't had to deal with a congenital heart patient in the emergent situation. Mm-hmm. They've always been elective, so by then, that information is known.
Okay. And as a follow-up, how about the non-invasive monitors, like the ClearSight? Would you recommend using that, or the Vigileos?
I have experience more with that outside of OB, more with like spine surgery and other complex cases. I actually don't know if it's been well validated in pregnancy, so I'd start there. I'm not convinced it has, and I don't have a lot of experience in pregnancy using it. I don't know if Dr. Nelson or Dr.
No experience. We've talked about using it in the fetal surgery setting when you're using high-dose volatile anesthetic to relax the uterus, and maybe there might be a role there to look at stroke volume and contractility, but haven't used it in the C-section or labor and delivery setting.
This next question for Dr. Nelson. At what blood pressure do you feel a vasopressor should be given? Like systolic less than 100, systolic less than 90, difference plus or minus 20%?
Right. So that 20% is what's most commonly quoted, right? It's in all the textbooks and in the literature. It's even used to guide studies when they make the decisions to give it. But just like I've already said, to me, there's no absolute number, and that's the problem with the difference between clinical practice and using it to try to fit what you read in journals and studies. We don't have, I recommend not having a specific rigid algorithm that you use. I think every patient is different and every case is different, and the way you approach it should be different. So if you have, and a 20% drop, sure, that's a good place to start if you're just going to do it that way. But again, like I alluded to in lecture, you all know, you've seen this, you run the gamut from on one side of the spectrum, a woman who needs very little phenylephrine or any vasopressor during the entire case and maintains the pressure well. And those are even normal patients, but certainly preeclamptic patients and one who have hypertensive disorders, sometimes they don't need anything. And I'll even extend that further. If you're using an epidural from labor and delivery rather than a spinal, a lot of them with hypertensive disorders will never need anything. So I don't treat any particular number. On the other end of the spectrum, I'll treat when I don't even have a number. When I've injected a spinal and they're saying they're already feeling numb, and I tell the residents and the students this all the time, watch that next print, give some phenylephrine, I guarantee you the next pressure is going to be 85 systolic. When they lay down and they say, wow, man, I'm really getting numb, or I'm starting to feel my chest get heavy, I'll even give 160 micrograms of phenylephrine under those circumstances, and I don't have a blood pressure. So again, no particular number, no exact, but 20% drop is a good place to start.
Next question, Dr. Ray, Dr. Rollins. Which complex congenital heart disease or heart disease is most worrisome to you in the fetus, where you're like, oh my God, I'm very maybe nervous or worried about?
In the fetus?
Or in the mom too. Or I'm sorry, in the mom. Which one?
For me,
Yeah.
the maternal complication that really gets me going is aortic stenosis and pulmonary hypertension. Those are the two that I'm most concerned about. In terms of the fetus, if neonatology wasn't going to be present, I think a hypoplastic left heart would really scare me, because you have to establish IV access very quickly. You have to start that prostaglandin infusion quickly to keep that PDA open, and you need to get that oxygen saturation near 75% to optimize systemic and pulmonary blood flow. And those are all things that I'm just not comfortable doing.
Okay, Dr. Ron?
I mean, I would have to, I can't speak really to the fetal, not being a pediatric anesthesiologist, but severe pulmonary hypertension is probably the one I fear the most.
And what's the main reason? Why? Why is it so scary?
I just feel like they're so on edge. Their heart's already strained, the right side, which isn't meant to handle those high pressures, and then small perturbations in oxygen status or CO2 can really throw them off, as well as the volume changes that occur right around the peripartum period.
Okay.
For me, it has to do with coronary blood flow to the right side of the heart. That right side of the heart is working really hard, and any drop in your systolic blood pressure is going to decrease coronary blood flow to the right side of the heart, and they're going to be at risk for cardiac arrest.
Right. And then, at least in the textbooks, they say if you have to do cardiac arrest in someone that has severe aortic stenosis, they're almost impossible, right, to bring back to resuscitate. So that's even more scarier too. Okay, last question goes to Dr. Nelson, and this came from an audience member. Dr. Nelson, please tell us the rest of your story, infusion versus bolus neo.
Oh, thanks. I obviously had the opportunity to finish telling that story. So what I'll do instead is finish the last question that I was going on with the thought there with the dose, which dose you choose. I have also found it very helpful to titrate the dose to heart rate. So under those circumstances that I just described, a woman lays down, she's telling you, I'm hypotensive. You can just tell her heart rate is 120 to 130, inevitably. Start giving phenylephrine, you're waiting for that pressure to cycle. It probably double cycles because it's so low. You give a second dose of phenylephrine, a third dose, and then a heart rate comes down from 120 to 80. You've given enough phenylephrine. That was the correct dose, no matter what her blood pressure is at that time. And in fact, then I tell the student or the resident sitting there, watch, this blood pressure is going to be 140 over 90. And sure enough, or maybe not that, 130 over 70. But a normal or just supernormal blood pressure has been restored once their heart rate comes down from 130 to 60, 70, 80. And if anyone wants to hear any of my other stories and be bored by that, whoever asked that question, if there are other questions I haven't answered, I'd love to talk to you guys afterwards.
Okay, excellent panel. Let's